I'm a surgeon, a full-time NHS surgeon that is obesity bariatric surgery, but I also do 1 in 12 major trauma on call. So I see obesity in a variety of scenarios, if you like, and I'm just going to talk to you a bit about how to do obesity as a disease and share some tips and tricks that you may find useful. This is my hospital in Bristol, the Southend Hospital. We took a picture on one sunny day of the year. It doesn't happen very often, but you're all welcome to visit and connect via email, social media, and by all means come and visit us. This is my conflict of interest. I work with a variety of organizations in this space of obesity, both in pharmacotherapy, surgery, endoscopy, but as I said, I'm a full-time surgeon, and that's probably my biggest conflict of interest. I'll start talking a bit about obesity as a disease. You cannot escape the fact that there is an obesity pandemic out there. The population that we treat in the operating theatre, in ICU, certainly your pain clinics, is changing, and it's not a small proportion of the population. It's now a true pandemic. And people seem to think that it's very easy, and there's endless debates about if obesity is a disease. Well, it is, and I'll show you why. The global rate of obesity is increasing. These are old figures. It's going higher and higher. We now have parts of the world with 40% of the population having the disease of obesity. There's a misunderstanding about what causes obesity and the complications of obesity. And I hear this very often, that it's calories in, calories out, and I'm talking to a room full of people who've passed FRCA with very good physics, and of course you all know the thermodynamics. The figure you see here is not modern art. This is true physiology. If you blow it up, you'll see that every part of it is a pathway, is a biological pathway, and this is what determines our energy intake. I'm going to try to personalize it to you, to just move beyond the physiology. Just think of you, all of you, please think what happened in the last 12 months in your life. Most of you would have a very similar weight today to what you had 12 months ago. But you have had days when colleagues of mine are overrunning as per usual because they overbooked the list, or they're unrealistic about their time, you're on call, you have no chance to have lunch or dinner. And then you have days where we consume huge amounts of calories in both liquid and solid form. And Christmas is coming, and we all know the days where we consume a lot of calories. But our weight remains the same. And people who say that it's calories in, calories out, they forget the part of our physiology that is energy expenditure. So you all spend energy. You spend energy whilst you're asleep. The amount of energy you spend, you cannot control, but I can control it for you. So if I put all of you in the room and I lock the room and I bring you a pint of milk to drink every day for 4 weeks, you will all lose weight, but you will also all reduce your energy expenditure because your body recognizes that you're trying to die out of hunger, and therefore it conserves the energy. And this is the reason why some of us eat ridiculous amounts of cake. And even for those of us who do not exercise, and again, I don't want to stereotype, but I'm sure a lot of you will be doing some exercise, or definitely a lot of my colleagues in Bristol are exercising a lot. But if you do no exercise, there are some of us that are able to eat ridiculous amount of calories and not put on weight. And that is not moral superiority. This is physiology, and you can see it here. It's those of us who can spend more energy whilst we're asleep, whilst we are, even when we're sitting down, compared to others who seem to get to put on weight even by just looking at the food sometimes. And of course, and I see very often that obesity is patients' fault. And I explain a lot of this physiology. If you ever need you have a bit of time, there's a website called itsnotyourfault.ie. It's based in Ireland. It's a non-commercial website. It's for our patients and for our colleagues, where we explain some of this physiology in more detail. There is this a wrong concept that, you know what, a little bit of stigma is good because, and we've all grown, when we're growing up, a lot of us, there'd be kids in our class that in school that would have obesity and people would pick on them. I used to think that a little bit of stigma is good because it motivates people. We now know this is completely wrong. There's exactly the opposite. Those of us who internalize our stigma get worse obesity as it goes down. And we can now say that obesity does not cause stigma. stigma causes obesity. And that's one of my take-home messages today. And the other one is that overeating does not cause obesity. Obesity causes overeating. And this is the physiology aspect I talked to you about earlier on. There's also this fallacy around prevention being a good way of treating the disease. So we all know that if your genetic makeup allows, and I will say that because if I knock off your leptin, you will get obesity. But if your genetic makeup allows, and most of the obesity we see is genetic, but a tiny proportion of it is monogenic, i.e. one gene. Most of us have a variety of genes that predispose us or protect us from obesity. But if our genetic makeup allows, and if we live a healthy lifestyle, so we live in the right part of town, we're in a well-paid job, we have the ability to eat very healthy foods, and we do our food shopping from a local organic market, and we cycle to work, and we do a lot of sport, we are less likely to get obesity. There is no doubt about that. But for those of us who get obesity, that approach is not going to help. Just like those of us who do not smoke are less likely to get lung cancer. But you would never tell a patient with lung cancer that they should stop smoking and expect a therapeutic effect. Sadly, we do this for obesity all the time. And I'll say the same thing as someone who does a lot of major trauma on call. Please wear your helmets, please wear your seatbelts. But for the patient who has a GCS of 5 in my ED, in RISUS, this is not the time to tell them about helmets. This is the time to intubate, get them across the theatre and help them out. And then we can do our population interventions down the line. So we need to treat this condition with a lot more respect and a lot more compassion. And I'll get into this a little bit down the line. Language does matter. And it's important to say that people are not obese. I mean, I do not tolerate any sort of terminology that is really damaging. But people are not obese, just like people are not hypertensive. People are also not cancerous. They have the disease. They do not get defined by the disease. And this is not just about being kind. This is also about accuracy. So I'm sure that all of you will agree that if my systolic blood pressure right now is 210 and my diastolic is 130, and I've had it measured multiple times in a pre-assessment clinic, I'm hypertensive. And that's the words we used to use, but actually that's not true, because if I told you this happened 6 months ago, and now I'm on an ACE inhibitor and a beta blocker and a calcium channel blocker, and my systolic is 120, I'm not hypertensive. But I have the disease of hypertension. Just like I may not be depressed right now, but I may have the disease of depression. Therefore, people have obesity, and a lot of the patients I operate on that get the BMI normalized, they still have the condition. And you would expect the resident surgical colleagues to document that someone has a patient of ours who is on the emergency list or on the elective list have hypertension, even though they have normal blood pressure, because they're being treated for that. It's really important that we recognize that. It's also important to recognize the heterogeneity of the disease. And I would say that in a few years' time, we'll be looking at obesity and could not believe that we thought it was one disease. Just like cancer is not one disease. We stage it. We know the difference between different organs, different causality. And also the treatment is heterogeneous. The most effective treatment for obesity is bariatric surgery. I'll get into that down the line. But what I want to show you here, this is the largest series of gastric bypasses in the country, 2,000 patients operated in the southwest of England, follow-up over more than 10 years. But you see there's variation. Some people do really well, some people do not so well. And this is not due to motivation or personality traits. This is biology. Just like some people do really well on the antihypertensive medication we start, and you can use a different diet. This is the Liractil diet and previous generation drug. And, if you look at the next generation drugs or the current generation drugs, semaglutide, tirzepatide, you'll be hearing this in the news. The shift is towards the right, but there's still a bell-shaped curve. Some people do really well, some people do not so well, and most people do average. And our ability to predict that is worse than a coin. We cannot get it right. And it's not the clever ones or the motivated ones or the ones who exercise more. It's just true biology. And we've seen this in animal models as well. This is endoscopy and this is gastric bypass. And you can see that every intervention has a bell-shaped curve. just like any other biological phenomenon. And we need to remember that obesity is just exactly any other disease. Of course, we need to consider all treatment options. Obesity is the only disease I know where we tell people to go back and do exactly the same thing they've tried 10 times before and expect a different outcome. Do this with lifestyle treatments all the time. People start a diet. Some of the patients I operate on, they don't only know about lifestyle, they don't only know about diets, they've written books about diets. But if it hasn't worked, it hasn't worked a few times before, asking them to go and do that again is actually harmful and, of course, wrong. So we need to escalate, replace the treatments that don't work, stop the treatments that don't work. We do this with chemotherapy or other tablets or medications all the time. If it's not helpful, stop it. All we get is side effects. As pharmacotherapy, and we're living in very exciting times when this pharmacotherapy is about to become a lot more available than it is now, and of course surgery, and even combine surgery and medications. I'm just trying to demonstrate this. That's what we do for cancer. We don't have debates or randomized clinical trials about chemotherapy versus radiotherapy versus surgery. We're trying to find the right combination of modalities to get the best possible outcome for our patients. And this is just one of the studies that demonstrated that. It was published in The Lancet many years ago now, almost a decade, where a randomized clinical trial so that even the most effective treatment options looking at diabetes remission at 5 years are not successful, but they demonstrated a significant reduction in cardiovascular risk, and therefore they saved lives. Another time I wrote an editorial on The Lancet with Carl LaRue, and we used for the first time the terminology and the concept of multimodal treatment for obesity and for type 2 diabetes. We need to do a lot more of that in this field. I'm going to take a pause now, and I'm just going to talk to you about cholecystectomies, because all of you would have been anesthetized for this operation. And I want you to think, I'm just going to talk to you a bit about the safety of bariatric surgery, but I'll do that by comparing with cholecystectomy. I want you to think about what is the risk you would quote for cholecystectomy. In pre-assessment clinic, or the patient in the anesthetic room asks you, what is the risk? And particularly, please think of a number. What is the risk of death you quote? And I'm going to show you some data from the UK. This is the COLIES study. So almost 9,000 patients over almost a decade ago now. And this is the 30-day complication rate, 7.1, the mortality rate, 0.15%. And this is the risk of injury. This is not a clinical trial. This is an audit done by our surgical registrars, residents, as we'd call them today, who did all this work. And this is the true 30-day mortality rate. Now, I have to admit that in my hospital, nobody ever gets told that they may die from a cholecystectomy. But there is a risk of death. Now, think about what is the risk of death you would quote for bariatric surgery, again, in the UK. This is not in clinical trials. I'm going to show you the National Bariatric Surgery Registry. This is data from the UK for the same period. Think of the number, and I'm going to show you now. So it's 5 times lower. The risk of dying from bariatric surgery is 5 times lower than dying from a cholecystectomy in this country. This is not how it's communicated. This is not what we see day in, day out. But this is the reality of it. And actually, that risk of death is compares extremely favorably with most of the elective operations we do, hysterectomies. It's safer than a major joint replacement. And this is on people with quite a lot of disease burden. Another way of understanding the bias we have for this disease, we do not take this disease seriously, we do not treat it well, and when we treat it, we completely miscalculate the risk of complications and the risk of death. You can see the complication rate is about almost half of a cholecystectomy, a well-established operation in the UK. And of course, it shows that while we don't do as much, and again, we probably do about 50,000 cholecystectomies in the UK every year, there are 3.4 million people living in this country who qualify for bariatric surgery, and we do 4,500 operations in the NHS. We have one of the lowest penetrance rates in the Western world. We have the lowest in G20. I'm now going to take a different turn and talk about management aspects and operationalize how, what to do really when you see people outside the bariatric surgery setup, in your standard anesthetic practice. You see people, with, about to undergo a total knee or total hip or cholecystectomy. How can we help you? And the first one is to understand if this is elective, if this is urgent, or if this is an emergency setting. So the things you can do in an elective setting, in pre-assessment clinic, that you cannot do in ED majors or in the, in ICU, or someone that has a cancer operation. You may have some time. Set the expectations. So I showed you earlier on, the reason that most of us who lose weight put it back on again is because of the physiology I described earlier on. But although weight loss may not be useful in the long term, it may be very useful for the day of surgery. That's a different expectation. So if I want to reduce my cardiovascular risk, the risk of getting type 2 diabetes, and I have a BMI of 40, losing 5% of my weight for 6 months is not going to give me that if I'm going to put it back on again. Divide and be clear about, are we going for weight loss or weight loss maintenance? These are different approaches, different treatments that we will need. And of course, we need to be a lot more precise in what we do right now. We are treating the disease in a very uniform way, but not understanding the heterogeneity of the condition. And finally, I really want to make a point about compassion. And I hear this quite a lot when I see patients who have been discriminated against their obesity in society, but also by healthcare professionals. And I would argue that, of course, there's discrimination in our society and this discrimination in our hospitals and in our NHS around pretty much every characteristic. But obesity is the only one that people who get caught doing that get away with it. And I think that absolutely needs to change. We cannot be talking about people who have this condition differently. And I think history will be very strict with us and unforgiving. And I want you to think a bit about how we treated epilepsy 100 years ago in the times of your grandparents, great-grandparents. If I had an epileptic fit in front of you, you would probably take me to the local priest. And epilepsy as a word means being possessed. It's a Greek word. I can tell you as a native Greek speaker that epilepsy means being taken over, being possessed. Of course, now we can treat epilepsy with phenytoin or multiple anti-epileptics, variety of treatments. We even have surgical treatments for it. And we have people who can be professional drivers, very well controlled condition. And I think that when we see how we treat obesity in 2024, in decades to come, we will look back and it will not be a good show. And we have led the way in the NHS of how to provide really compassionate treatment. And we have some of the best, still not good enough, but we definitely led the way of palliative care. I do a lot of cancer care, and we provide compassion. The vast majority of people who get diagnosed with cancer have metastatic disease at presentation when it comes to upper GI cancer. I see a particularly bad forms of cancer, pancreatic cancer, esophageal cancer. But we provide compassion, even if we cannot provide cure. And we need to do the same thing for obesity. And just because we don't have good treatments doesn't mean that we cannot be compassionate. And I always say that the only treatment that works via the intra-auricular route, via our ears, that is successful is words of compassion. And we don't do this enough in obesity. I'm going to talk some technical aspects now of how to operationalize this. And the first one is kit and equipment. And, I hear very often, I get referrals from the whole region saying, oh, can you please do this laparoscopic cholecystectomy? A hospital does not have bariatric beds. And to me, that's unacceptable. We have an obesity epidemic out there. We need to have the kit for our population. Our CT scanners have to get better. And I always say, let's learn from other epidemics. Look what happened with COVID-19. It was acceptable, although still not good enough, not to have masks in April 2020 in our hospitals. And, colleagues of ours, we've lost colleagues of ours because of that. But that would not be acceptable today. And it was not acceptable in 2022. So in obesity, how is it acceptable? How have we normalized that we do not have the kit for the population we look after? We have to change that. And we can learn from the obesity units around the country, and the Society of Bariatric Anaesthesia has a very good network of centers, and of course there's a lot of bariatric centers in your region. The minimally invasive approach used to be contraindicated in people living with obesity when I was starting as a surgeon. People say, well, have to do this open. It's actually quite the opposite. It is really advantageous for people living with obesity. Laparoscopic surgery has a much more bigger benefit in people living with obesity than not. And robotic surgery is again much better for that. The perioperative care. Again, I'm not going to talk to you about bariatric anesthesia, but you can look at bariatric centers and see the safety that people undergo in anesthetic in bariatric centers. So my standard list will have 3 gastric bypasses and then some 2 or 3 more cases later in the day. They're not bariatric, usually laparoscopic. Most patients go home the next day. 23-hour stay, about 80% of our patients will go home the next day. And these are people with BMI 60 and 70. And I see my anesthetic colleagues doing this day in, day out. We can provide good perioperative care in people living with obesity. And the training, the way to have that is visit those units, have a discussion with colleagues who do bariatric anesthesia as they have the volume of experience. And finally, think about the very low energy diet, a diet that we use very often, often called liver reduction diet or liver shrinking diet. And what we do is that we give 1,000 calories a day, usually with meal replacement. It's very hard to actually have 1,000 calories a day. We do this for 2 weeks, we go up to 3 or 4, but not more than that without any nutritional complications. The standard is 2 to 3 for most bariatric centers in the UK. The liver volume reduction is about 25%, really shrinks. But what it does do, it also reduces insulin resistance. And as you all know, that has an impact on complications, particularly infections. And this is a randomized clinical trial we did in the Karolinska Institute in Stockholm, where we measured insulin sensitivity before the diet. We randomized patients to the diet or normal diet, and then after the diet, the next day we operated. We measured it again. We measured it 2 weeks post-op and a year down the line. And you can see there's a bit of weight loss with a very low energy diet. It's not great, it's about 4 or 5 kilos. But what's really important to see is that there is an improvement in insulin sensitivity. That's on the right hand of this graph. You can see that the gray bar on post-diet is higher, and it's almost the same as 2 weeks after bypass. All these patients had type 2 diabetes, and you can see an insignificant improvement. And I think we underutilize this. You do not need a dietitian. Our waiting list coordinators usually give this in an A4 page. It's only for 2 to 3 weeks. It should not be given for longer than that without monitoring. And patients tolerate it well. It can be tough, but they tolerate it well when there's an endpoint. What we cannot do this is for long-term treatments of this condition. And I have some data here to demonstrate that high glucose levels do cause harm, and interestingly, it seems to be worse for people without type 2 diabetes. There's potential explanations to that. But either way, what I really want to say is that giving people an intervention to reduce insulin resistance is a good thing. I'll move on from that because I want to keep some time for the question, also give you a bit of time back. I hope I've convinced you that obesity is a disease, and we're now moving from, I have moved and from is to as. I will not debate any further if obesity is a disease or not. I'm treating it as a disease, and it's all about multimodal care approach. Thank you very much for listening. These are my colleagues.